Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we are going to talk about a third episode of pediatric epilepsy series, and we will talk about how to diagnose seizure or epilepsy in clinical practice. Now, when a patient comes to me and the family tells me, we had an episode of seizure, or the pediatrician or one of our colleagues referred the patient to us for further evaluation for seizure. From my side as a pediatric neurologist or a child neurologist, we do the following format of evaluating this patient. First, you have to take a history. Remember, history and history and history. We ask the family about the details of the events. We ask the family if they have a video. If they have a video, that's awesome, because one picture worth 1,000 words, one video worth 1,000,000 pictures. So that will be helping us big time. We make sure we ask if the patient, what exactly happened with him. Did he lose his consciousness? His eyes were open or closed? Was he drooling? Was he completely unresponsive? Was he having jerking all over? Or one part of his body was jerking? Did he lose sphincter control, pee or poop on himself? Did he go into deep sleep after that? Very important, we ask about the family history. Does anybody in your family has seizure? Okay, and you ask the mom and the dad, and I usually ask them, please, dig into more detail and see if anybody in your family has a seizure. Any recent injury to the brain, any history of injury to the brain in the past, what time usually his seizures happen, because there's specific type of seizure that happens only at night, and some of them during the day, and some of them happens all the time. Now, after I take the history, and if I feel, his history is consistent with a seizure or is highly suggestive of seizure, okay, I go ahead and order for him an EEG. And EEG is to look at the brain wave activity to see if there's any electrical discharge, what type of discharge, which part of the brain is this discharge coming from, and also we order a brain MRI to look at the brain itself if there's any issue. Remember, the video has a sound and picture. So the sound is the EEG, and the picture is the MRI. So I have to have the EEG as well as the MRI to complete the picture. But remember, by the end of the day, the diagnosis of seizure is a clinical diagnosis. What does this mean? If I have a patient who is his clinical history and looks exactly and is consistent with seizure, and I do an EEG and this EEG is normal, that does not mean that the patient does not have a seizure, because by the end of the day we depend mainly on the signs and symptoms to diagnose the seizure. And the other way around, if I have patient who comes to me, for example, he has a history of headache, and an EEG was done for him for whatever reason, headache should not have an EEG done for it unless it is very specific, rare situation. But in general, 99% you didn't need an EEG for headache, and the EEG is abnormal. And you ask the patient, did you ever lose your consciousness? Did you ever drool? Did you ever lose track of time? Did you ever go into deep sleep, unexplained tongue biting, unexplained loss of sphincter control? Anyone have anyone in your family so you having gelatin chronic seizure? And he say, no, I've never had this one, or I have never had any issue like this. Then this is not seizure, and whatever is in the EEG, either it is not read very well, or either it's an incidental finding, because the EEG, which is the brainwave test, 1% of the population might have an abnormal EEG, but they don't have a seizure. Remember, history, and history. The most important piece of information is what you take from the patient. I just got online consultation from Egypt 2 days ago, and the patient has been in 2 medication and she is not well controlled. And when I asked the mom, what is the episode? She told me she has a very bad headache, and she started crying, and she feels like she is not feeling well. Okay, and I asked her about all the signs and symptoms of seizure. She did not have any, but the EEG was done, and the EEG was read as abnormal. Most likely, is a misreading. It was not needed to start with because we are dealing with headache, and she was started on one medication, and she did not improve for seizure. Then a second medication, and she did not improve, and the mom was very surprised because I told her, you are putting her on seizure medication for a headache that has no relation with epilepsy. If I have a seizure, I do an EEG. If I don't have a seizure, I don't do an EEG. By the end of the day, I depend on the history, thorough history, by experienced physician, preferably child neurologist, well-trained child neurologist or pediatric neurologist, and this will be more than enough to diagnose a seizure. Imagine you are practicing in Somalia and there is no an EEG machine. EEG machine is not mandatory for me as a child neurology to practice. It is very helpful, and it's extremely helpful. By the end of the day, it's a clinical diagnosis. I hope this piece of information were very helpful for you guys, and please wait for me and in the next episode, and we will be talking about how do I treat epilepsy, and also what are the medication we're going to be using for specific type of epilepsy. Dr. Hamza Alsayouf, consultant child neurologist. If you like me, give me like. If you like the video, and subscribe to the channel to follow the upcoming video. Thank you and have a good day. Bismillah ar-Rahman ar-Rahim. Dr. Hamza Alsayouf, consultant child neurologist, American boarded. Today we are gonna talk about how do I treat epilepsy, and how do I treat seizure. First, in the previous episodes we talked about how to diagnose. We want to make sure that what we are treating is actually a seizure or not, and then second step, we need to classify what kind of seizure. So the first question is the event a seizure or not. Second question, what type of seizure. Then based on what type of seizure we go for the medication. There's two main type of seizure. Okay, regardless to the recent classification that they make it more fancy or dandy. For me, as a consultant child neurologist who are heavily clinically oriented, it's a partial onset or generalized onset. Partial onset means it starts in one part of the brain and spread all over around. Okay, generalized onset, it starts in the brain everywhere. And if it is a partial onset based on the clinical history and the EEG, or clinical history alone, or the EEG alone, the best medication to start in these cases is oxcarbazepine. Second medication is a levetiracetam. Third medication is Vimpat. Then after that you go for Tobamax, Lamictal, and Dibakine, and so on. So if it is generalized onset, I usually start with levetiracetam, then topiramate, then lamotrigine. Okay, now here very important point you need to know, and everybody need to know about this one. When we choose the first medication, we start low and go slow. What does this mean? This medication range of doses is, for example, 10 milligram per kilogram up to 60 milligram per kilogram. Let's talk about oxcarbazepine. 10 milligram per kilogram to 60 milligram per kilogram. I start low and go slow. I start by 5 milligram, then go to 10 milligram, then 15, then 20 milligram. Then I stop. If the patient is well controlled, he does not have any seizure, he does not have any more episode, I keep him on this dose. I make sure during the follow-up, adjust the dose to the weight, especially if there's a big weight gain, and keep seeing the patient every 2 to 3 months. Now, here a common mistake. If I take the patient, and here the level from 10 milligram to 60 milligram. I go ahead and put him in 20 milligram and stop. Then the patient has a seizure. I push up the dose, I make it 40, then I push it, I make it 50 and stop, okay? I still have, I can go up to 60. As a child neurologist, I can go up to 80 and sometimes 100 per kilo. You know, I stop here. So I never pushed up the medication to the maximum. Okay, then I add another medication. And they do the same thing. Then I add another medication. That's called Spice's style of treating epilepsy. And this is one of the commonest mistake and the commonest reason for patients who are not well controlled seizure-wise. You have to start low and go slow. You need to keep going up, up, up until one of three things happen. Either I hit the maximum dose, or the patient can't tolerate the medication anymore. Start off side effect, rash, dizziness, vomiting, sleepiness, or I control the seizure. So if I start the patient in 20 milligram per kilogram and the patient sees, that does not mean that this medication is not controlling his seizure. It means the dose need to be pushed up. Very well-known example I always tell my family about. The first time I came to Dubai, I was consulted in a patient at one of the local hospital here, and he was having 30 attacks of seizure per day. It was a complex partial seizure. He has seizure and started crying, and he was at that time on 5 medication: Keppra, topiramate, triliptal, dibakine, and steroid was added recently. Now, for me, you know, it was a shock for me. How do I control a patient who is already on 5 medication? But at the times when there is no rules, stick with the basic rules. So what I did, I took all the medication and I calculated how much does he take per kilo. None of the medication he was taking were near the therapeutic dose. All the medication were halfway at the best. I still remember he was on oxacarbazepine and he was on 42 milligram per kilogram per day. We know oxacarbazepine is the best medication for partial onset seizure. I pushed the oxacarbazepine, I made a 62 milligram per kilogram. His 30 attacks per day went down to 1 attack per day. Then I pushed it further to 71 milligram per kilogram, 0 seizure. You know how important I should, you know, optimize the medication. Then I took all the medication out, and he was on his way for epilepsy surgery in Canada, to Canada, and then we canceled all that, and he was very well controlled for 1 or 2 years. Then he disappeared for a follow-up. Then, so very important to know what's the type of seizure. Very important to know which medication is best for that kind of seizure. We start low and go slow. We push to the maximum, or until the patient is well controlled, or until the patient does not tolerate the medication anymore. And this will conclude our episode today about how do I treat seizure. Remember, this is in general, simple, basic information just for the family to know more about seizure. Dr. Alsayouf, consultant child neurologist, American boarded. Thank you and have a good day.